During intern year, I introduced myself to Mr. Smith, an older white gentleman. Hello, I'm Dr. Adetoye. I'll be taking care of you during your hospital admission. Later in the day, when the attending led us back to the room for team rounds, Mr. Smith addressed me as a nurse. The word hung in the air, but no one, including the white male attending physician, addressed it. The intersectionality of being a woman and a woman of color meant that I was unsure which triggered this comment, but was uncomfortable either way. After the incident, I considered faculty with whom I could discuss the experience. I found that within my department of more than 100 faculty members, there were only 3 Black physicians. This lack of diversity meant that if I wanted to process, I would have to rely heavily on the 2 Black women within the department. As an intern, I didn't yet know anyone and felt it would be a burden to ask for their support. I realize now that I did not want to add to their minority tax burden of being the only Black women within the department. Thus, even in early residency, I faced microaggressions and occasional macroaggressions without support from mentors. So fast forward to my final stint as the night call resident in my last year of residency. I was working on our inpatient service at the rural hospital. As I sat in the workroom completing documentation, I overheard people discussing the merits of the police kneeling on George Floyd's neck. 2 male voices argued that since we did not know the crime and Mr. Floyd was resisting arrest, the method of restraint was justified. A female voice agreed, but felt the police should not have allowed Mr. Floyd to die. I stepped out of the workroom to get a document from the printer and found 2 white security guards and a white nurse staring at me. They immediately stopped talking and cast their eyes away. I quickly grabbed my document, made my way down the hall toward the call room. At that time, I passed a Black security guard and with a sigh of relief thanked him for being there. He was watching the news on his phone and said, "You're welcome, doctor. Things are getting crazy out there and he would be here all night. If I needed anything, do not hesitate to ask." I thanked him again, slipped into my call room and began to cry. As the sole Black resident in this white rural hospital, I was afraid that the security guards who were supposed to be there for my safety, for the safety of all, were actually discussing the merits of murder. I believed that there was a Black security guard in the building and felt an innate, almost unspoken understanding with him. That night, while admitting patients, I considered how to navigate the situation. This time, I was a 3rd year, one who was empowered and fed up. I felt it was time to share some of what I had been experiencing with my residency leadership. To my surprise and pleasure, frankly, they were concerned and responsive. At that time, we established a diversity committee at the rural hospital with a goal to create a more inclusive environment for staff and patients. So, gone are the days where academic medicine can assume that the day-to-day experience of seeing patients is uniform for all. Minority physicians need support and guidance around these difficult encounters to successfully navigate training. Research shows far better patient outcomes and patient satisfaction when there's racial, ethnic, and language congruence between patient and clinician. Building trust between leadership and minority trainees is a pivotal component to increasing trust in medicine overall. I think the onus should be on the programs and departments who train young physicians to strive to create a safer and more equitable environment for all, so that someone like me does not feel like a burden to my supervisors. This can be done by taking several steps, because I always have steps to take. Number 1, have an understanding of the communities in which trainees are working. Identify particular challenges which might arise, for instance, having a Black physician working in an overwhelmingly white community, and communicate those with trainees. 2, be vocal about the program's intolerance of discrimination and discuss how the program can support trainees, including identifying faculty and staff who can support individuals. 3, educate the attending physicians and preceptors about these incidents, provide education and training about how to address microaggressions when they arise and how to debrief affected trainees. 4, consider highlighting mentorship, advising, coaching from interested faculty who are racially, ethnically congruent with the trainees, so trainees do not have to seek these out on their own. And 5, institutionalize these policies so that they are not dependent on the goodwill of the individual. So to my intern self, I would say, it is not your fault that this occurred. You would not be burdening leadership to discuss this with them. It is your program leadership, along with the institution's responsibility, to provide a more inclusive learning experience for you and other minority trainees. Although you do not know them well, they are here to help you succeed, much in the same way they're here for your Caucasian colleagues. You deserve this education. Tell them.
This past spring, while I was home in New Orleans studying for the dreaded Step 1, I fell back into a role that I held for many years, that of accompanying my mother to medical appointments. You see, we moved to the United States from Venezuela when I was 11 years old, and since then I've become my mother's personal interpreter, as she does not speak English. What was special about this specific encounter, however, was that for the first time in countless similar appointments, a healthcare provider asked my mother about her sexual life. In medical school, I've grown used to asking sexual histories, and I've been burned on clinical examinations for not bringing it up. So I've learned to incorporate it into all of my encounters. Yet it was not until that moment that I realized all the times that ubiquitous and slightly uncomfortable topic had been avoided with my mother. After all, talking about your parents' sex life is awkward enough to leave a long-lasting impression. At Feinberg, I've been a fierce advocate for Latinx representation and medical Spanish courses for students, faculty, and staff. If we want to tackle the health inequities that plague immigrants and other communities of color, patients need to receive culturally competent, quality care in their language of choice. And I genuinely believe that the ideal way to provide this care is one-on-one, without the additional layer of screens and telephones diluting our relationship to our patients. Hence the importance of training future generations of providers that are multilingual. Time, nonetheless, is as equally important of an investment, and one that is often scarce in clinical context. Finding an interpreter takes time. Waiting for the interpreter to listen to your question and translate it, for the patient to process it and answer it, and for that response to make its way back to you takes time. As a result, we often cut corners, not out of any malicious intent, but in an effort to be efficient. We try to make do with our patients' broken English. We economize on areas of the history that do not seem presently relevant. We trim down the pleasantries that help us establish rapport. And in doing so, we forget to build relationships to our non-English speaking patients. And we deprive them of the opportunity of being full, complex individuals, as opposed to chief complaints under our care. Recently, on a busy Sunday in the trauma service, one of our patients spent the entire day alone without any updates, only for his surgery to be postponed later in the day. The next day during rounds, this patient rightfully expressed his frustration, saying, "Yo no soy un perro." I am not a dog. I am a human being, and nobody could be bothered to stop and answer my questions because I am Mexican and don't speak English. Yo no soy un perro. My chief resident immediately halted rounds and apologized profusely, taking the time to listen to this patient's complaints. By the end of his hospitalization, he seemed to have completely forgotten about this incident. I, on the other hand, have not. While I can make excuses about the unpredictable nature of the trauma service or the lower staffing on weekends, we need to be able to hold ourselves accountable for this mistake. The patients need to be heard in these situations. Like him, I cannot help but wonder if we would have failed so remarkably had our patients spoken English. In that fateful encounter with my mother, after the awkward laughs and the uncomfortable silence, I actually felt really grateful to that provider for bringing up her sexual life, as awkward as that may sound. Because in that moment, she gave my mother the opportunity to discuss her concerns, whether now or in the future. It is seemingly small mistakes like this ones that we have discussed, repeated time and time again, that slowly erode the confidence of marginalized communities in our healthcare institutions and our ability to provide them with adequate care. While I cannot ask all of you to go home and immediately learn Spanish, I can ask you to take the time to build relationships with your patients that do not speak English as if they have lives outside of the hospital, and to ask all of the relevant social history questions, even through an interpreter, even when you're busy. I know that what I'm asking is not easy. Enlist your medical students. Go see them after rounds. Do this every other day if daily is not possible, but do not make excuses and find the time. Thank you.
My name is LaShira Nolan, but most folks know me as Lash. I'm originally from Compton, California, and I am a second going on third year medical student at Harvard. And my story really starts this December when I was getting a lot of text messages and calls from my family members concerned about these new vaccines that were coming out. And during this month, we were hearing a lot of conversations about trust and this idea of mistrust in Black communities around the vaccine. But what I was hearing from my family members, they were genuinely concerned about whether or not this was something that was going to be beneficial to them, or was this going to be another way of the medical institution and our government institutions causing harm to our communities. And during that month, I was hearing a lot of discussions about historical instances of why Black communities were being hurt by the medical institution. So a lot of folks were talking about Henrietta Lacks. They were talking about the untreated syphilis experiment, but there was really a failure to recognize the ways that our communities experience health disparities and racism on the day-to-day basis within the medical institution. And then at the same time, I started to reflect on the fact that there was this great paucity of Black physicians who looked like my family members who were in the medical field, especially when we consider our doctors. In 2019, JAMA came out with a study that showed that if because of the closure of the Black medical schools as a result of the Flexner report, there was a decrease of over 30,000 Black physicians who could support our communities. And that was something that was definitely coming up in December when people were having questions, looking for trusted messengers to help share this information about the vaccine with them. And then it all culminated when there were studies coming out in December that were showing that there was a more likelihood for Black patients to want to seek more information about the vaccine if the provider looked like them. So it was this theme of trusted messengers coming up over and over again as this conversation about the vaccines being approved were coming up. And I remember being home during Christmas break, and I was sitting there saying, LaShira, you are in your clinical rotations. You do not have time to do anything to address this problem on your own. But it just kept coming back to me. And I realized that if I didn't do anything, then my community would be left behind. So that's when I reached out to Daniel and I said, Daniel, I have an idea. And I think that this idea will be We Got Us. And what we would be is a coalition of Black medical students, healthcare providers, community activists, and folks who are genuinely dedicated to having conversations with our community members about the vaccine. And we started in January of 2021. And now, about 7 months later, we are a full-fledged organization with amazing pre-medical students who are leading our charge. And we've been able to touch over 1,000 people in the Commonwealth here in Boston, Massachusetts. We've had different events in Brockton, Massachusetts, and also at different schools here doing comedy shows, all around having candid conversations about the vaccine. Every week, we're out canvassing in various communities, having conversations with folks and getting them access to appointments to get vaccines, putting on vaccine clinics. And it's been truly a blessing to get to do this work. And all of the work that we've done have been under 3 pillars. The first is to empower through education. The second is to convey, not convince. So we're not trying to convince people to get the vaccine, but we're trying to convey information to them in a way where they feel empowered that when they decide, I want to get this vaccine, that they have all the tools in their toolbox to make that decision for themselves. And then lastly, we're putting public health first. So we've seen a lot of back and forth from our government leaders saying, okay, you should wear a mask. Well, we don't know if you really need to wear a mask. And it's been quite confusing for people. But for us at We Got Us, we've always held that social distancing by investing in policy that allows people to be able to social distance, to make sure that they have equitable access to housing and masks and PPE. Those are the sustainable measures that are going to allow us to move forward outside of this pandemic and make sure that people are able to live out a healthy and happy life. And those are the things that we've committed to. And moving forward, we hope to continue to do the same with different health topics such as chronic diseases like hypertension and diabetes, really bringing health to the people and allowing us to do that in community together. And I think the lessons that I want to share about this idea of trust that I've learned from We Got Us and what I hope that our team can show you all is number one, that access isn't just about physically accessing the vaccine. It's about access to education about the vaccine. Who traditionally has had tools in being able to understand the science behind vaccines because of who has had the privilege to enter medical careers and fields and have those trusted messengers. Thinking about language barriers, thinking about access to time and that privilege, thinking about access to paid work and paid leave. And these are things that thankfully are being more approached and listened to now. But at first, we weren't really considering the big A access. It was this little A access of how are you physically going to get access to the vaccine without thinking about the other barriers that exist beyond that. And then the second thing that I want to share is that trust is really a tall order and it requires deep work. When we ask someone who's been marginalized traditionally by our institutions to get vaccinated, what are we really asking them? We're asking them to forgive years, decades of harm and hurt. And we're also asking them to do something that's going to protect all of us. So it's not as simple as that ask, but really thinking about what are we really asking that person to do? And what forgiveness are we asking for in that moment when we might not even deserve it in that moment? And what work do we have to do to earn that trust? And then the last piece I want to share is that a lot of us have shared this idea of getting back to the new normal, but who was really benefiting from the normal that we had before? And how do we create a new normal? How do we create a new standard where everyone can trust and where everyone has space to live out healthily and to live out their best lives? And that's going to come from thinking about all of the different projects and fundings and efforts that have been erected as a result of this pandemic and making those efforts sustainable so that our communities don't feel forgotten about once we get our economy and our communities back running again.